Oh, so sorry. Oh my God. So I guess the questions that I created overnight did not allow me to put 1 minute. So if you see the white questions show up, these are the ones that I created yesterday. So my sincere apologies. For every question, you have to switch the toggle for 1 minute. My bad. But orbital frontal, the whole reason why I created those questions is because people asked about, I don't understand the orbital frontal and the anterior cingulate process, because both of them do what? Impulsivity. Now, orbital frontal is more towards the ADHD, really. The impulsivity, the modem actions and answering, blurring out answers, or moving fast without thinking. When we think of the anterior cingulate cortex, it's more of it's more of a selective attention, because if I don't necessarily filter out what's important and what's not, then there is impulsivity tied to anxiety. Okay, but anterior. So how would that play out on the task? It could be someone that is older, 60 years old, with anxiety, and ask which brain region is it associated with, right? So anterior cingulate process, cortex, should be a good answer. Now, the middle two is a big drive for anxiety and fear, right? But if the question is related to impulsivity in someone with anxiety, anterior cingulate process. If the question is related to ADHD and impulsivity, orbital frontal. If the question is related to ADHD, inattention, dorsolateral prefrontal cortex. And we all know that the prefrontal cortex is hypo functioning. That is also keywords, okay? Everything that we talked about now is keywords that you should know. 10 seconds, pick your best answer. Okay, if you see a white background question, that is a 20-second question, okay? So read real fast and pick your best answer. Okay, so yesterday we talked about tolerance. Tolerance is nothing but needing of the same substance to achieve the similar results when they first started, right? We see a lot of tolerance with ADHD medications, benzos, right? Alcohol, but can also happen with SSRIs. If the question is about someone that been on SSRI for 6 months and it was working and now it's not working, it may not be about tolerance. You have to assess, assess for psychosocial disturbance, right? Now, if the question doesn't bring anything about psychosocial disturbance and it's clear that after 6 weeks the medication is not working, or after a while it's not working, then the logical answer is to increase the dose. Okay. All right, so that is ADHD. Sometimes it can be confused with autism, right? So knowing the difference is very important because tons of questions will be about ADHD. Not only what is ADHD, how can you define impulsivity type versus inattention type, or a mix of both, how to administer medications, when to switch medications, if someone develops a tics disorder while on a stimulant, what should you do? And obviously, the brain regions and neurotransmitters that are involved with ADHD. They are not hard questions, but it means you need to know the content. Okay, it really means you need to know the content. 20 question, 20 seconds, please go. 10 seconds, go. All right. So good. Right. The point that I was trying to link here is that if you have someone, very few questions on the board, it's not about the patient. This is probably the one that I love the most because it's a real question in real life. So many times, moms specifically, they come in fighting with dads, and dad says, I think she has ADHD. And mom said, you're crazy, and then we're like in the between, and what should I say? And this, well, according to what we see here, is most likely ADHD. And the mom breaks down. At that point, it's not about medication. It's about providing brief supportive therapy to the parents. Very few questions. Psychiatry switches from focus from the patient to the caregivers, and that is one of them in real life too. Very common, very, very common. Okay. The next time you guys meet, you can talk about the medication, but right now, it's all about addressing the emotional um, support to the family. Because guess what? They don't care about how the medication is going to work. They care that their children, their child, have a ADHD, and this is all what they heard. They didn't hear anything else, right? So all you do is support brief supportive therapy to the couples, to the mom or dad or whoever, okay? And later you can talk about medication, how it can be helpful, how it can increase self-esteem and help the child thriving. Always remember, kids taking stimulant could cause insomnia and delay in growth. So we always have to check weight and measurements to make sure that they're still eating and the dose is appropriate. 20 seconds, please go. Inattention, ADHD. What's the answer? 5, 4, 3, 2. Perfect. Very good. But that is the reason. Remember, inattention,
Yeah, here. Go to the car.
inattention. Someone
I
has a
don't
mic.
know.
Someone has a mic on.
I'm gonna
Kindly,
stay right here until we're all ready to leave.
man, you have your mic on. Um, Remember, inattention, dorsal, lateral, prefrontal cortex, impulsivity, orbital, frontal. These are very, very, very high yield questions. Impulsivity related to anxiety, anterior cingulate cortex. All right, good job. So I kind of broke it down a little bit more here, specifically the ACC, right? Which is more really more than impulsivity is selective attention, filtering, unable to filtering the distraction. Okay. And that causes to be impulsive, picking something. rather than picking nothing, for example, right? But anterior cingulate process is also in real life is a really selection or selective attention process. Okay, so all right, 10 seconds. All right, three, two, one. All right, good job, everyone. Almost 100%. Remember, SSRIs are not for ADHD, right? If you want to use a non-stimulant, you could consider Wellbutrin, guanfacine, strattera, or clonidine. These could be good options, but SSRIs are not for stimulants, right? And thank goodness no one picked Ativan. That would be extremely bad. All right, 5 seconds. Pick your best answer. Go. All right. So here the dilemma is obviously, let's start off with the obvious. Not so obvious, right? But everyone should know. If someone develops a tics disorder, or whether it's a Tourette's, whether it's a vocal tic, whether it's a modem tic. Yesterday we broke it down that we need to know about Tourette's. We need to know um, two modem and one vocal tic. And we need to know that has been there, the symptoms for over 1 year, and has happened before the age of 18. These are the criterias for Tourette's. Why is that important? Because you will need to know provisional tick. Well, what is provisional tick? One that has been there for 8 months, less than 12 months, for example. Okay. If it's just a modem tick, then it would be a modem tick or provisional modem tick. Can be a provisional vocal tic or a vocal tic. By knowing the characteristics or the DSM-5 definition of Tourette's, we are able to get another 5 questions. Okay. Now, if someone develops a tics disorder while on stimulants, we need to stop the medication. So therefore, Ritalin is not an option. Neither Vyvanse, right? These two are stimulants. Now to the harder answer. Why not atomoxetine? It is a good answer. However, if your goal is to help the child with ADHD symptoms and control the modem tic, guanfacine, guanfacine, or clonidine would be the best answers. I know there are questions out there that will tell you pick Stratera. I promise you they would be wrong. Stratera would have been a good option for a mother that says, hey, would like to start him or her on a non-stimulant option and has nothing to do with tics disorder. Stratera probably would be a better option. But if the question is related to tic disorder, guanfacine and or clonidine, preferably guanfacine. All right. So if you read the question, at the end of the question said, which of the following is the most appropriate initial intervention? Would that be the initial intervention, behavior therapy, focus on symptoms reduction, or do we do education first for mom, dad, and Mia? Right? I get it. The red option is very tempting, and if you pick the red options, I totally get it why. But focusing on what the question is really asking at the end, what would be the initial intervention? Education, psychoeducation, right? All right. If you send your borderline patients for ECT, that's not a good thing, okay? It's not a good thing. So I trust that was a mistake. Maybe the phone is small and you picked something fast, but ECT is not for borderline. Now, inpatient hospitalization, nobody picked that. And antipsychotics medication, very rarely, but could be considered. What is the treatment of choice? Is DBT. What is important about it? Who created DBT? Marshall Lyham. What is the goal of DBT? to decrease self-harming behaviors, right? And kind of understand what DBT is to some extent. Why would that be important? Because in DBT, everything is like a clock. Even the therapist, even the therapist needs therapy after a full round of DBT. But think about it. If you are in a room with 10 borderline patients, you're probably going to need therapy. And that is part of the protocol. It's not like, oh, I don't think I need it. You have to. It's part of the protocol. If you read the protocol, it's very strict. But why am I happy on this? If you get a patient with borderline personality disorder and all of a sudden this explosion emotions and they become a little bit aggressive, you have to be firm. Sir, this is not acceptable. If you don't stop right now, we'll have to cancel this appointment. That's it. You have to be firm because they have problems with boundaries. And if you make the boundaries even less unclear, the problem only gets worse. You're not helping them. You have to be very firm. And sometimes the firm answer does not appear to be a therapeutic answer, especially for the board. But it is what you need to do. But always being respectful. There is a difference between being firm and disrespectful, right? You're not going to call them out and be like, let's do this, right? That's not what I'm saying. You have to be firm on your answers and what are the expectations, okay? Okay. The question said, hold on, hold on, guys. 1 second, please. Okay. Okay. So, very hard question, right? Extremely hard because some aspect of avoidance personality disorder and the the social situation, social anxiety disorder, they kind of like intertwined, right? So it was a very hard question, right? Because the question said extreme discomfort in social situations. So almost puts you, at entirely in a social anxiety disorder. But here it captures the core of a social inhibition, hypersensitivity to criticism and rejections. So as you can see, they are almost twins, right? Avoidance personality disorder, they don't like social situation because they do not want to be rejected. So they create this barrier in front of them that says, I will not be rejected. Simple as that. So therefore, I will not be social. A coping mechanism. So this was a very hard question. Okay. Very, very hard question. So if you picked, um, if you picked, what was that answer? If you picked, uh, social anxiety disorder, I can 100% see why. Okay. But it goes more in details. And this why it was a very hard question. All right, 5 seconds. Pick your best answer and go. All right, very good. I don't think we need any explanation. Schizotypal is the weirdo one, right? The magical thinking. They have oddness to the extreme, but that is a personality disorder, not schizophrenia per se. Okay. You need to know schizotypal versus schizoid very well. Oh, here we go. All right, 20 seconds. All right, that is paranoid personality disorder, right? If you pick schizoid, there is s- some symptoms of a schizoid in there as well. I can see that, but there is nothing about borderline personality disorder and a little bit of a generalized anxiety disorder, but not really, right? So when we think of a schizoid, is the one that prefers to be alone in the basement, doesn't want to talk to anyone, indifferent to praise or criticism, simply doesn't necessarily care, um, about socialization. And that is the core feature of schizoid that you need to pay attention compared to schizotypal. More of a weirdo, magical thinking, uh, things that are very, very odd. All right, 5 seconds. Pick your best answer. All right. So now we got it almost 100%. Maybe it was um, you picked the incorrect answer, not because of a knowledge gap, but because sometimes it happens. Okay. So yeah, that is all the telltale signs of autism spectrum disorder. And remember, it is a spectrum, right? Some of them need stronger medication. Some of them can do it just with therapy. Okay, good. right? 5 seconds. Perfect. So you need to know applied behavior analysis, ABA, high yield, right? Now, please do not neglect, not related to this question, psychodynamics, psychoanalytics. Read up a little bit about it, okay? Because that is important. Lots of questions, psychodynamics, psychoanalytics, just kind of knowing who created, what it's about, the suppressions of emotions and feelings that we're not even unaware of. Okay. And obviously, CBT, who created CBT and what is CBT helpful for? What is what's cognitive behavior therapy? These are very, very important questions. Very happy. No one sent this person to ECT. That's a good thing. Okay. I know, man. I feel like maybe it was just a fast finger, but I don't know. Sometimes I'm like, I don't know if it is uh, someone pressed incorrectly or do they really want to send the patient to ECT, right? So ECT are for the last resort, right? We covered ECT yesterday, I believe, a little bit, or the module before, I think it was, yeah. Um, ECT is for major depressive disorder, resistant to medication, most likely with psychosis. Now, ECT is for schizophrenia. After we have tried all other medications and have not worked, ECT is absolutely the last resort, right? It works really well, but it is dangerous. There are contraindications and requires a lot of resource. Okay? Yes, depression with psychosis. Okay, depression that has been resistant to medication. Very, very few patients qualify for that. Four seconds, three, two, one. All right. So yesterday we called DMDD, oppositional defiance disorder, conduct disorder, and IED. Think of an IED as an explosion, like a bomb that just goes off and suppressed afterward, right? Think of it as road rage to help you remember IED, right? So the patient recurrent, sudden, fast, from nowhere episodes of verbal aggression and property damage, disproportion to the external stressors, and the feeling of attention just before and the relief after is the telltale signs of ID. Okay. The question says, I don't know. What does it mean? Helping someone. 5 seconds. The question outside hopeless, right? So I tried. Why is this not a dimension, right? And definitely not vascular dimension, right? Pseudo dimension equals to measured pressure disorder. That's all what it is. Patients with pseudo dimensions are older adults that present with symptoms that are similar to dementia. However, they do not try. They say, I don't know. This is too hard. Takes too much effort. I can't do it. Right? That is pseudo-dementia, which is a fancy name for depression. Okay, how do we treat those? SSRIs. Okay. Now, compared to dementia, they will confabulate. I don't know is keyword. Confabulate is keyword. They show up on tests all the time. You can get books that were made 20 years ago. They still cover the same thing. I don't know. I don't want to try. Do this questionnaire. No, it's too hard. I don't remember. They don't try. That is pseudo dementia, which is equal to major depressive disorder. Now, you ask a question for a dementia patient, man, they'll create a beautiful story and give you the best answer they got. And they're not doing this on purpose, but they're filling in the gap in 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 their memory. They're not trying to lie to you, but they're giving you their best effort. I love dementia patients. They're fun, funny. They're like, "Oh, Dr. Love," and the next day they don't even remember me. I'm like, "What happened?" 3, 2, 1. Okay, I knew that some people would get confused NDRIs versus SNRIs, right? Think of the SNRIs or the medications that help patients with pain, duloxetine, effexors, and there are others, Zimbalta. Yes, absolutely. Now, TCAs too can help with pain. However, TCAs can cause cardiac dysrhythmias, right? So start with the lower gun first, Zimbalta, Effexor, right? And then if that doesn't work, later you could suggest TCA. Now, if the patient says, I do not want medications, a good option for depression and pain could be acupuncture. So if someone says, I do not want medications and they prefer acupuncture, do not discourage them. Here is the research. This appears to be a good option. I support your decision. Okay. These are the answers that are high yield for the board. All right. So I see that most of you guys are in my class because if we had even if we had suicidality as option B, we would not pick suicidality. We would pick sexual dysfunction. Okay, we would pick sexual dysfunction. Now, if this patient was a 21 years old, the number one concern would be suicidality. Okay, so suicidality would be the number one concern for 21 years old, 23 years old, and below, 24 years old and below. I would be more concerned about suicidality. At 42 years old, most likely sexual dysfunction is the main concern. 3, 2, 1. All right. So just because it said what is the initial action, right? There was no indication of someone that was bleeding, having cardiac distress, respiratory distress, right? It doesn't mean that you automatically go take the vitals, right? This is a manic patient that's talking. Clearly, he's manic. What is the most important thing I should do at this time if there is no physical signs of injuries or decompensation? Now it's psychological, right? So for that reason, assessing the current level of self harms to self and others is the most important step. Would we still do coping mechanism? Yes, but that's down. Take the vitals? Yes, we still would take the vitals, right? Make sure he's not is actually mania and not something else. And we still will assess medication history, absolutely. But the number one initial action here is assessing for self-harm behaviors. All right. So if you give an SSRI to somebody that's already manic, you're gonna make them double manic. There is no such thing as double manic, right? But you could potentially, in theory, and in real life, it does make them more manic. So we definitely would not give a SSRIs or any antidepressants. Now, the question that I want to highlight to you is, would lithium take away the auditory hallucination? No, right? So I think that was a given away in the repeat of the first question that we had. Someone's manic, olanzapine. Now the question was even nicer by saying auditory hallucination. So we have to learn from our mistakes so that we don't repeat those mistakes. We all make mistakes. I make mistakes all day long, right? There is nothing perfect about me. But we have to kind of walk back and see, learn from our experiences so that way we can get the next question right. Okay. So hopefully now, everyone, if you get a question similar to this on the board, it will not be the same question, obviously. You get it right. So I'm glad that you got it wrong because we learn from our mistakes more than we learn from victories and things that we do well. Okay. So please understand the reason why. So that way, if you get a question similar to that, you get it right on the board. Do you remember on your NCLEX, you got a question similar to this, to some extent, right? Your question was probably the symptoms of hypo and hyperthyroidism. We probably got a question on both of them on NCLEX. I promise you did. If you don't remember, if it was 20 years ago, I still remember, right? So even if you didn't know the relationship between T3 and 3/4 and the TSH, you should still be able to figure out this was hyperthyroidism because it gave you the symptoms of hyperthyroidism. With hyperthyroidism, everything is fast, heart rate. They have heat intolerance. They eat a lot and gain no weight. That's a good thing, sort of, right? They can't sleep either, right? So, um, yeah, and hypothyroidism mimics depression, cold and slow, stomach blockage, lethargic, and hates the winter. Okay. Now, for those that are in the class, I bet you that you really got this right because you saw the inverse relationship between T3, T4, right? And the TSH is high. When we say the TSH is high, we're looking at 0.4, 0.3, 0.2, 0.1. And I think that's what give it away. But even if you is not in a class, these are classic symptoms of hyper and hypothyroidism that we need to know and CLEX type questions. All right, 10 seconds. All right, so glad that most of you guys picked up on the cue of the previous question of hypothyroidism. It follows the same question as the previous question, but now it gives you the symptoms of hypothyroidism in addition to the elevated TSH level of 12. Anything above 5, specifically if the T334 is in an inverse relationship going down while the TSH is going up here, in this case, then this would be a hypothyroidism. But again, it gave you right from the beginning cold intolerance. All right. So do not give benzodiazepine for somebody with generalized anxiety disorder. That is very different than panic
Tato.
attack. Even on panic attack, we have to look for better options before we give benzodiazepine, right? The board does not like benzodiazepine. I hate benzodiazepines because they work. They work really good. But the reason why I hate them is because anything that works really good is addictive. I don't care what it is, right? Uh, Call it sex, drugs, alcohol, whatever that is, that thing, it can be very addictive. And taking someone out of benzodiazepine is hard. It's probably one of the hardest things in psychiatry. Okay. So, how do we treat generalized anxiety disorder? The same way we treat major depressive disorder, the same way we treat OCD, the same way we treat trichotillomania, right? So, the same medications, just maybe a tiny bit higher dose often. Um, Specifically for OCD, will be a higher dose. 3, 2, 1. Perfect. Okay, it's a panic attack. We need to know the difference between panic attack and panic disorder, right? Impending sense of doom. That is a panic attack. So panic attack is one, panic disorder or many panic attacks. Why do I really care? Well, because the treatment is going to be different. For panic attack, for panic attacks on the board, we prefer not to give a benzodiazepine. So what we would start with at least hydroxyzine, Vivitrol. I mean, I'm so sorry, not Vivitrol. Hydroxyzine, Atarax, right? It would not be unreasonable to even think of boost power. Would not work, but you know, now if these choices are not, then there is only a benzodiazepine, then it could be the answer, right? Now, for panic disorder, we give a SSRIs, okay? And that is the reason why I care that you know panic attack versus panic disorder. In real life, what they're going to give you for panic attack when you come to the AD, here's your benzos. This is not real life. This is the board, okay? Let's see if we can get 100%. All right, close. I think that's pretty close. But some people got stuck on generalized anxiety disorder. Even though I can almost see it, right? Because the question said over 6 months. But the reason why I said over 6 months, the symptoms aligns with panic disorder, right? Not generalized anxiety disorder. But for the board, when you have excessive worries that is over 6 months, that is generalized anxiety disorder. And the 6 months is key terminology we need to know. But the question did not emphasize excessive worries. It really said, hey, this person's having excessive panic attacks, right? The symptoms.
Dr. Lopez, you're on mute.
Thank you so much. Appreciate that. Why is this not conduct disorder? Let me give you a trick just between you and I. If you read the question and you think, I would put this kid in jail right now, then that would be conduct disorder. That the description that was provided, someone is misbehaving, Not acting appropriately at home and in school does not follow the rules. There is opposition to the rules or defiant to orders. That is the definition of opposition defiance disorder. It gave it away by saying does not follow the rules in schools. Teachers are complaining. The kid is not killing cats, is not putting fires in on buildings and eating popcorn and watching the thing burn out, right? That is conduct disorder, right? So when we talked about positional defiance disorder, it really is much lower than conduct disorder. Now, when we say conduct disorder is a precursor of what's coming up next, antisocial personality disorder. If you look at the DSM-5, it says for antisocial personality disorder has to be over the 17 years old. More specifically, they need to have the traits of conduct disorder even if they were not formally diagnosed in childhood, right? And this is why we need to send them for parents and uh, parents teaching skills behaviors training to help them get a hold of those kids before they progress to antisocial personality disorder. All right. So, okay, there's nothing to explain here because everybody really got it, right? So there was the spouse argument followed by the neurological symptoms cleared by neurology. Easy peasy. All right, very good, guys. Excellent. Right. So remember, if you read the question, it said, what is the crisis? A recent divorce with financial stability. How does it make you feel anxious and depressed? So there is an adjustment disorder with anxiety and mood. Now, the question was pretty giving, right? It was pretty easy. Now, think of a harder question, a medical diagnosis, right? Because you don't necessarily may think a medical diagnosis could be the cause of how they feel. that may seem to be like an anxiety disorder or major depressive disorder. Pay attention if you can link a crisis, whatever crisis that is, and my crisis will be different than yours, right? To my kids, their crisis every time we move city, because we move city every 2 years, they get into a crisis mode, because friends are important to them. They get in a crisis mode, right? So if they start misbehaving after we moved away, that is an adjustment disorder, as long as they didn't misbehave before that, right? Or felt depressed and anxious. All right. So while I do believe that maybe if you pick the wrong answer because of the phone, right? It was an identical question of the previous question. And we just kind of went over the explanation. The same scenario, almost identical, happened again. One question after we explained it. So if that was you that picked the wrong answer, I get it if it was a mistake. But if it was because of a knowledge, we got to get together. We have to get together, hurry, like, because it's going to be trouble. Okay. So the sooner we identify those troubles, we can prevent a catastrophe. Okay. Because we just went over the question, and I'm not trying to be rude. I'm trying to help you before it happens. Okay. So if you don't understand the adjustment disorder versus generalizing disorder versus a conversion disorder versus fractation disorder versus malingering disorder, we have to get together. The good thing is, well, it was just module 3, so next week is going to be therapy. So, but please, we have to get those questions. Those are not very hard questions. And I'm not trying to be mean, okay? I'm really trying to help you here because it's going to be problematic. I know some of you guys were looking for prazosin, right? But remember, FDA approved medications for um, PTSD, sertraline, and Praxil, right? Any SSRIs would do it, in theory, at least. Now, if the question was about, are we treating PTSD or are we treating nightmare? nightmare, prazosin, PTSD, SSRIs, specifically Praxil and sertraline. Sertraline is very good for sexual traumatic incidents. I like sertraline. Okay. Now, yeah. So just remember yesterday we talked about EMDR. Specifically, we talked about exposure therapy and image rehearsal therapy. If you get a question and you're looking for EMDR and you don't see it, and you see this weird answer that is image rehearsal therapy, that could be the right answer. Okay. All right. So this was a pretty good question. Everyone got it. Nearly everyone. Um, so OCD. Remember, the compulsion can be a tick. Don't jump to Tourette's when you see ticks. And remember, pandas, streptococcal infection can cause OCD. These are very high yield. How do we treat OCD? SSRIs can be a good option. Okay. Hmm. Okay. Very good. Kind of hard question because we always talk about which one is it. But here was about Tourette's, right? It's an excess of dopamine activity, which is of the leading theory, pathophysiology for Tourette's. But remember, Tourette's is not just one thing, right? Several things: DNS, dopamine, norepinephrine, serotonin. But sometimes, if you were put against the wall and asked to pick one, dopamine would be an excess dopamine activity. Last question is a 20-second question. 20-second question. 3, 2, 1. Uh, Good job. Sorry about the super fast question there, but I think we went over in detail the dorsolateral, orbital frontal, and anterior cingulate because they're very high yield. I can almost promise you got an extra 3 points for being here today, at minimum. Okay, so here's the rationale. Why would that be a best option? Okay, think of anterior cingulate processes selective attentive attention, right? So specifically with the anxiety, and that may lead to impulsivity, the wrong signal. Dorsolateral, inattention for ADHD. Orbital frontal, inattention for, impulsivity, sorry, for ADHD. Amygdala now can be tricky, right? Because amygdala is all in the neighborhood of anxiety, right? As well. While it can is the fear center, specifically with smells. Like the smells can bring us memories, right? Oatmeal cookie, something from childhood, or a traumatic experience, right? That generates anxiety, could generate anxiety or pleasant, right? So, all right. All right. Third place is, okay. Second, Kathy. And first place, all right. Friend, you again. I know you won last time, friend. What are you doing? You spend all the nights working and studying. Good job, friend. Good luck. Good job, everyone. So for some reason, did not give me the the, the, the fifth. Oh, it did. G G and V. So good job, everyone. I know it's challenging. Friend, second day, second Kahoot in a row, you're making the first time. Go, friend. Yes, absolutely. So amazing. Good job, everyone. That is awesome. So remember, next week is the hardest week, right? Because it is all about therapy. So I did a document under module 4. Please review the document that at minimum it's going to minimize the things that you need to know for therapies. There are tons of therapies, tons of names, they're all important. So revise that and print the paper and put it next to your bed. Every morning you will get up and you talking about solution focused therapy, family system therapy. Go through the details. It's not that many. If you get just what is in the Microsoft Word document that I created for you, it will help you tons. The key is repetition.
Next week.
Next week is module 4. Okay, so yes, absolutely. So what we'll do now is I'll have a few minutes to kind of answer a few questions real fast. I can't, let me see if I can go back to, I don't think I can go back to the question. It does not allow me to go back to the question about the 6 months. Let me see if I can go back here. Give me a second, real quick. Somebody had a question about the 6 months, and actually, I can't go back. But since you asked the question, you can go ahead and unmute yourself. Tell me a little bit what was confusing about the question. I can't bring that question back up.
Oh yeah. Good evening, Dr. Lopez. This is
Good
Kathy.
evening. Hey, Kathy.
Yeah. Yeah. The problem, what I noticed was that when I was going through the narration and everything, I saw 6 months. So that was a bit confusing because
Right.
when you're talking about adjustment disorder, it has to be at least within, it should be within 6 months, not over 6 months, majorly.
Yeah.
And when it comes to maybe within 1 month, that should be acute stress disorder, right? That's the way I differentiate them. So when I
So,
saw the 6 months, it was just misleading. But I later saw that I saw irritability. That was the only thing I can really pinpoint.
okay. So Are we talking about adjustment disorder or are we talking about acute stress disorder or PTSD?
No, the answer to that question was what I picked major depressive disorder.
Okay.
So, but the answer was adjustment disorder with conduct and mix maybe
Mm,
anxiety or something like that.
okay. So let's go back to that in terms of a timing. Is usually, there is a crisis and the symptoms persisted for around 3 months, right? So now the question is, whatever the crisis was, is it still there? If the answer is yes, it didn't go away. So it's still an adjustment disorder. Maybe a chronic at this point, but usually it's like this. If you, let's say, you have a boss that's picking on you, you quit the job, and then for the next 3 months you feel upset, angry, and anxious. That would be an adjustment disorder. Now, if you're still at the job and your boss still picking on you every single day, the insult or the crisis never went away, so therefore the symptom is still persistent. Does that make sense?
Hmm.
A little bit. So
Yeah.
yeah, I can see why the 6 months kind of can be uh can be a good thing and a bad thing sometimes, right?
Mhm.
But I would have
I wish we
oh,
can just see that question again. It will have been good for
yeah,
at least for us to able to maybe analyze it so and see where we got it wrong.
yeah, let me see here. Let me see if I can reopen a new Kahoot. Let me go in my email here real quick. All right, while I'll do that, let me get somebody else questions real quick, and then we have to go. I know, Easter, my apologies. I know you had your hand raised for a while. Do you still have a question?
Is it me, Isabel?
It was Easter first,
Okay, okay, that's fine.
then Joyce after that. Easter, you muted.
Hello.
Hi there.
Hi, how are you? I'm on,
Good.
I'm on the road, but I was just asking. You said something about unit module 4 that you posted something, and when is the class?
Module 4 is next week, which is therapies, and has been posted a while. It is under the first module of module 4. There is a document there
Okay.
that kind of simplifies therapies
Okay.
a little bit more.
All right. Okay. Thank you so much.
Okay.
Dr. Lopez, I think we have crash course next week.
This is next week.
No, crash course is the 28th and 29th.
It's next week.
Wait,
Oh,
Next
man,
week.
it is.
Yep.
It is next. You're right.
What are the hours for the crash course Eastern time?
10 in the morning. Sorry, my days are getting blurred. Yeah, so my apologies. You're right. Thank you so much for correcting on that, because I would hate
Don't
to.
drive so much on the thing.
So
So narrow.
remember
You can't see
next
very
week. Remember that next week, no live classes during the week. We are going to spend 20 hours together on the weekend, Saturday and Sunday. Okay, very, very high yield. This is when you practice the 600 questions that I sent to you via email, which is a preview of the crash course review. We have the crash course question bank, which is the super high yield questions for your test. The 600 questions is just to help you figure the topics out early on, okay, before the crash course review. And then what happened is, on Monday, Tuesday, Wednesday, it will be tons of people passing the board. This is usually a wave. People wait for the crash course review and test immediately after. If you completed everything, if you're good, If you've done your diagnostic test and you score more than 80% the first time, can't take 5 times and say I score 100. That doesn't count. You should be good to go. Okay.
So, Dr. Lopez, where can I find the 600 questions?
I will be sending those via email. Okay. So watch for an email from me with the link and the 600 questions. So your job for next week is to focus on the 600 questions. It does not matter where you are in the course right now.
That's what I was gonna ask because I'm
Yeah.
I'm still on.
It does no, it does not matter. So you should stop. I mean, everyone's situation is different, right? Generally speaking, you should stop because this is an important event and just focus on learning those questions. And it does not mean if you don't do well, it doesn't mean anything because honestly, we don't know. Maybe you join us this week. Obviously, you're not going to do that well, but you still do it because there is the benefit of the rationale and there is the higher benefit of when we are covering the content, you already went through it in a similar format and helps you put everything together. Okay. Now, if you don't want to do it because you're only starting now, it's okay. We don't limit you or you can only attend one crash course review. We're all in, right? There is no limitations to what we say you cannot do this or that. That is maybe other people's business, but this is not us. We want you to come to as many classes as possible. We want to support you. We want to be there for you. We want to make sure that you know the material so that you can have the best outcome. So it's up to you to say, now I'm going to focus on my module. That is okay. You have another opportunity to do the crash course review another time. Or I would suggest focusing on the crash course review, even if you have not completed the modules, because it will help you the most. But it's always a choice. All right. Let me get here. Joyce, are you still there?
Yes, Dr. Lopez.
Hi, go ahead, please. What is your question?
So I was reading on the WhatsApp page, and a lot of people are talking about taking it the second time is the hardest, and
No,
I
not
missed it by 4 points, so I'm really
so.
worried.
No, you shouldn't be worried. Okay, if you didn't pass the first time, it's totally okay. Now, if you're taking this 3 times, you should be worried. So what you need to do is make sure that you have all your dots in a row, all the T's are crossed. Make sure that you learn from experience. I'm gonna tell you, Joyce, you will pass.
Thank you, Dr. Lopez.
Okay, just make sure that you stay encouraged and you stay doing the what you need to do. You will pass. Usually people have a higher success rate on the second time because they already been bit by the dog, right? If you've been bit by a dog, you don't want to be near the dog anymore. So we hope that no one has to go through the experience so that they'll be like, oh man, I have to get on it. You'll be okay, Joyce.
Okay,
All
and
right.
just to let everybody know that I joined this class after I didn't pass, so it wasn't from this class that I prepared. And then most of the things you went over on the crash course review, because that was the week that I joined, so I just joined the crash course. And as if I'm looking at my exams questions, like most of the points that you went over were on the test, but I didn't know it
Yes.
before. So
Well, this time, Joyce, you will. Your confirmation whether you are going to pass or not is your diagnostic test. That's why we do extra things. We push you to the limits. I'm always nagging you guys to review the PDF and do things because I don't want you to feel regrets after. I want you to feel happy and ready to go and move on. So the hard work is before the test. After the test, during the test, is going to be a breeze. You will see. You come back, you'll be like, how come what you said is very interesting because a lot of people feel so bad because after they gone through our course, they feel like I didn't pass the first time. It wasn't, everything was here. After I joined the course, I can see everything clear, right?
Yeah.
So I get that a lot.
okay.
So, yeah.
All right. Thank you so much.
All right. So I'm getting this question here again. I'm looking for this question. So let me see. While I do this, let me answer the second question real quick. I don't have a whole lot. Maria, you're next, Maria.
Yeah, hi, Dr. Lopez.
Hi.
Hi, can you please explain the treatment for panic attack and PTSD again? I kind of missed that part, please.
Okay. So panic attack has nothing to do with PTSD, but
No,
the panic attack.
panic disorder.
Okay. So
Yeah,
panic attack,
yes.
we want to do probably a Atarax, right? Atarax or hydroxyzine. We prefer not to give benzodiazepine. Okay,
Correct.
for the board.
Okay.
Panic disorder is mini panic attacks or many panic attacks,
Sure.
and the treatment now would be an SSRI.
All right. Okay. Thank you.
Did I answer the right question?
Straight to the point. Thank you.
Okay, all right.
Yes, thank you.
So no problem. So the next person is RNTI. TI, are you? Tia? TI?
Yes, Dr. Lopez.
Hi.
I think you already answered. I was gonna so I was scheduled for this week Saturday, but I put it off because of my schedule is so tight. But yeah, so I'm looking forward to the crash course review next weekend. And I was gonna ask you, are we having live class? Because usually we don't have live classes when we had the crash course review.
Right,
So I'm
right.
looking forward to doing those 2 days because I've been to the crash course review before, but I was at work, so I missed some of it. So I just put it off until I at least do your crash course review and then
Perfect.
I'll test it.
I think that is a great
But I
choice.
think I'm ready. I started doing I did 1 and 2 diagnostic tests and I
Mhm.
scored in the 80s. So I'm looking
Good.
forward to passing. I
So,
just need to concrete a few things, you know.
okay. Yes. My advice is to go over in depth of the documents that we have on the crash course review. Do the
Okay.
600 questions.
Yes.
Do the question bank crash course review.
I
Question
did
bank.
them. I
Okay.
finished the crash course. I finished the question bank.
Okay.
So
Hold on.
I'm starting the 600
Okay.
questions.
Perfect. I
This
just want to make sure that you know there are two different things. Perfect. And
Yes,
then
I know. And I printed all the crash course reviews. So I'm starting those this weekend.
perfect. All right. So here's the question that some folks had a concerned about. We have a 30 years old woman presents with psychiatric clinic with recent history of significant life stressors. So that is, why is recent, right? She reports feeling of sad, anxious, and overwhelmed since losing her job. So what is the crisis? Losing her jobs, how she felt, sad, anxious, and overwhelmed. She also admits to having difficulties controlling her anger, engaging in arguments with friends and family, and occasionally becoming physically aggressive. So that is your disturbance of conduct. So now we have the adjustment was losing her job, either mix of emotions, depressed and anxious, with a disturbance of a conduct. Did it help after we went over the breakdown of the question? Someone had this question, right?
I was the one that asked the question. Yeah, it
Yeah.
helps.
Okay,
Thank
good.
you.
Absolutely. I was able to go back to the game and kind of like and look it up
Okay,
why.
thank you.
Absolutely. So, Lyra, you have a question?
Hi, Dr. Lopez. First of all, I
Hello.
want to thank you. I just passed my ANCC today.
Whoop, 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 whoop.
And shout out
Good.
to the WhatsApp group. It was very helpful. They were all very supportive. My question is, I took it today, but then I registered for the AANP as well. When do you recommend taking it? And what should I focus on? Should I do the crash course again, or what should I do?
You need to test immediately, like uh, on the Monday or Tuesday after the crash course review. Now, some people have told me we can only follow one blueprint, otherwise it would be too crazy, right? If we try to
Mhm.
cover everything, it would be too crazy. But some
Great.
people have told me that our crash course review highlighted document, it was 70% of the person's test. Now, the good thing to you, Lyra, is if you already master the content, you will pass the next board with no problem. Almost 100% of our students that pass one board will pass the next. So
Okay.
what you do not want to do is go on a vacation, take a long break, and
Mhm.
then go test it. So you are ready. I would just kind of maybe go over the question banks again, but now it's light work. You don't have to be like, burning the midnight oil anymore. Light work, one more week, next week, after the crash course review on Monday or Tuesday, if you are okay with your life situations, go test it.
And regarding the question bank or the diagnostic, which one should I focus on?
There are supplemental questions. I
Yeah,
think
the crash course day 1, 2, and 3.
yes, but
Yes.
below that there are supplemental questions. You can also do those questions if you already have done the previous required questions, right? So you wanted something new.
Okay.
Does that make sense? Because if you already
Right.
done the other questions, now there is little value of repeating what with repeating what you know. Go for something more challenging. Those supplemental questions. Okay.
And for the modules, should I do? I mean, if I have time, skim through the whole 1, 2, 3, 4, 5.
Only PDFs.
Okay, sounds good,
Only-
doctor. Thank you
Yeah.
so much, and you have a good night.
Good night.
Thank
Is it
you.
All
a
right.
must you have to take the ANs, the other one?
No, you don't have to. But why? Everyone is different, and there is good reasons to do it and good reasons not to do it. But to me, if I put all this effort, $200 is nothing compared to the benefit. What could be the benefit? Let's say Lyra study and she didn't pass, but she studied and she was very nervous and didn't pass on Friday. On Monday, she can go right back and try the other one and pass instead of waiting 2 months to test again. That would be the benefit. Well, of course, she passed, right? I'm just saying,
Uh,
if
Dr. Lopez,
yes,
what's the need of taking the exam again? Is there any specific need for that?
if you don't pass the first time, you
No,
have
if
to
you
wait two
pass this,
months.
no, if you pass this, because she's
No,
planning to take another test and
well,
she passed.
she probably was thinking ahead just in case if something happened and she didn't pass, she want to save herself 2 months of work by taking the next test. Now, maybe, right?
Yes,
Now,
that's exactly why I did it. I was just making sure I have, backups. You're
yeah,
right, doctor.
yeah. I mean, to me, it makes sense because 200. I don't know how much it costs. I don't know if it's $200. It's nothing compared to one day of you having to. You make more money in one day than $200. So if you have to pay $200, right, it makes sense to save yourself 2 months of agony in having to take it again, the same test. I would go for the next test immediately, right? But again, it doesn't mean it's the right answer. It's just my own perspective on it. All right. TL, are you there?
Yes, Dr. Lopez.
Hi.
It's Cynthia.
Oh, it's
So,
Cynthia. Hi.
yeah, I just want to figure out. I've not been getting email notifications for the class or updates via email.
Perfect.
For this class, I had to go to the WhatsApp group to literally ask if there was a place to find the link, and someone shared the link with me. So I'm not sure why I'm not getting any communications or update via email for the classes, especially the one we have coming up next week.
Okay. So TL, in order for me to know, you have to send me an email. I will look it up your account. But the first thing I would do right now is actually go back to your um go back to your spam box and search Kahoot.
Okay.
Most likely, if you have a Yahoo account or sometimes Hotmail, my emails are delivered straight to the spam box. So then what you need to know is either add me as a contact and add me as not spam box. That would be the immediate action that everyone should do it because I have a system that says delivered or not delivered for whatever reason. Sometimes could be because the email address is not correct. So we have to investigate. But 90% of the time, 99% of the time is because they arrive to the spam box. And obviously, you're not looking there, and you may have thousands of spam box emails, makes things difficult. Just search for Kahoot. And if you received it today and there's in your spam box, now we know what is the problem.
Oh my God, it's been going to my spam. So the last time I received an email from you was on the 2nd of this month.
Mm-hmm.
So, and I also got the Kahoot. Okay.
Yeah, so just mark as if you have a Yahoo, mark as in your contact, and mark as not spam, and then respond to the email sometimes. Hey, I received it. Sometimes it helps you clear up the confusion. Okay.
Okay. All right. So we should expect a link for the 2 days class.
Yes, ma'am.
Okay.
Probably by Monday, start sending emails, and they will probably repeat Wednesday, and they will repeat Friday, and they will repeat Saturday morning before the event. Okay,
Oh,
just to make sure.
can you clarify what you mean by repeat on all those days? Is it the email or the actual class?
No, yes, thank you. It's the email, right?
Okay.
Just to make sure that people are tracking and they're adding to the calendar, and I'm always repeating the same, hey, we have a live class, we have a live class. So I do it several times before the event.
Okay. Perfect.
Okay,
All right.
awesome.
So much.
All right, thank you. Isabel, are you there?
Yes, I'm here. So I'm not part of the WhatsApp group from what I know. Because I've
Okay,
not been seeing anything on WhatsApp. I know I've been answering questions on Facebook, but I
okay.
don't know about WhatsApp group, what people are
Please,
talking about.
please send a text message via WhatsApp to, I'm going to put in a, I'm not going to, I'm going to stop recording here. Uh, to send a text message via WhatsApp to 240
Wait,
389
wait, 240
389
389
8213.
8213. And my second question is, I'm doing, I think my package is just a question bank and the crash course review question. So I did a question, I'm doing the question banks now. So what are the other 600 questions you're talking about?
You'll be receiving that via email.
Oh, so I should first of all do the crash finish.
Yes, so you'll be getting that to complete before the crash course review. Now, Isabella, remember that I added for you the diagnostic test.
Yeah, I've seen that one. I'm not taking it because I want to do
Okay.
the question bank first. Is that what I'm supposed to do?
Yes.
Or then I do the diagnosis test. That's what that was my
Yeah.
plan
No,
to finish.
it's good. Now,
Okay.
just I'll be sending you an email with the 600 question probably by Monday. Okay.
Thank you. Because I want to get it so that I get the crash course. I mean the class on the 28th, and maybe plan to take the exam really like right then. I
Okay.
don't know. Depending on how
So
I do.
yeah, so if you are planning to do that, then you need to plan to do your diagnostic test this week.
Yes, that's what I'm thinking to do that this week.
Yeah, do that. I think that's a good plan because that way you kind of know what happened is, you if you need to make adjustment and is in the last day, it's kind of hard.
Okay.
Okay.
I will do that. I'll do the
Yeah,
test
and
this
if
week.
you have any questions about anything, communicate with me. Give me a little bit time to respond, but I will respond to everybody's email. Okay.
Oh, okay, thank you.
All right.
All right.
Easter, are you there? Easter.
Yes,
I
I'm here.
think it's a mistake for me.
Go
Is it
ahead.
mine?
Yes, Easter.
Hi, Dr. Lopez. Good evening.
Good evening. Oh, I'm so sorry. I muted you. My apologies there. Go
Okay.
ahead.
Hi. Yes.
Hi.
I
Yes.
have I have two questions.
Sure.
I'm just gonna repeat what I've been hearing. So just if I have if there's any if I missed it, just let me know. It's about panic disorder and PTSD, I believe. So for panic disorder, the treatment is SSRI, correct?
Yes.
And then for PTSD, I think I was hearing Praxil and one other medication.
Okay.
I'm not sure.
So no, you're right. So let's go back to panic disorder versus panic attack. Do you know the difference between them?
Yes.
Okay.
So panic attack is when it's happening for the first time,
Okay. And
and
how do
that's
you treat it?
with Atarax,
Perfect.
yeah, or benzos if we say that, but not that's real life, right?
Okay. Yes. So how do you think? Do you treat panic disorder?
That's with SSRI. So it
Perfect.
could be, yeah, it
Okay.
depends on what the option.
Now let's talk about PTSD.
Okay.
PTSD, the treatment of choice is EMDR, is
Okay.
not medication. If you're looking for EMDR, you don't see it, look for exposure therapy or image rehearsal therapy. That is important. Image rehearsal therapy. Okay. Now, if they ask for pharmacological treatments for PTSD, SSRIs would be a good choice. More likely sertraline or Praxil. Now, any SSRIs would do it, right? Fluoxetine could also be used. Lexapro could also be used. Okay. Now, if the questions about PTSD and the target symptoms is in nightmare, prazosin is the answer, right? Because people tend to see PTSD and look immediately for prazosin. It's not what the question's asking, right? If the question is asking nightmare related to PTSD, then the answer is prazosin. Prazosin. Does it make it a little bit clear or not? You're
It's
muted.
clearer.
Okay.
It's clearer now. Thank you.
All right. Do you have another question?
Yes. Then the second one I wanted to highlight on was on the anterior cingulate.
Okay.
So that's for when the question says impulsivity and being anxious, correct? I go for that anterior cingulate.
Yes. Impulsivity related to anxiety. Yes.
Anxiety. Okay, and then when it's mostly fear and anxiety, it's the amygdala.
Yes.
And then when it comes to inattention, it's the
Dorsolateral.
dorsolateral.
Yes.
And
Yes.
then when it comes to impulsivity and not paying, yeah, impulsivity, that with ADHD, that's orbital frontal, correct?
Yes. The just one thing that I wanted to add to this, it was perfect, by the way, very good. I would say know that the prefrontal cortex is hypofunctioning.
Hyperfunctioning.
Okay.
Okay.
Perfect. Any other
Okay.
question?
No, that's it. Thank you so much, Dr. Lopez.
My pleasure. Linda, are you there? Linda?
Yes, good evening,
Yes,
Dr.
I'm
Lopez.
here. Which Linda?
Is it my Linda?
Yes, the Linda with a heart.
Yes, that's me. Good evening, and thank
Good
you so
evening.
much for all you do. Well,
Yes.
I'm done with the diagnostic 1, 2, 3, 4. The scores were pretty much okay. They were good somewhere in the 90s, rest one in the 80s, mid 80s. And but I have a question.
Sure.
It's not related to module 3, actually module 2. I just want to be cleared.
Yes,
Yeah.
please go ahead. Ask any question.
Um, for experts, when do we use it? I'm kind of confused. Yeah.
Can you repeat the question?
Expert for screening for substance use disorder.
Okay. So Seabird, right? Asbird. Different pronunciation though. So let's say somebody walk in the door and knocks, can I come in? Yes. Then you are going to use that as your general, you don't know anything about this patient. you are going to, what does it stand for to begin with?
A screening,
Okay, so somebody knock on the door, you are going to screen them. What's
brief
next?
intervention,
Brief intervention, you're going to provide brief support and then
re-
refer, right?
refer. Yeah,
Then you are going to refer to the right treatment,
yeah.
right? And then while you do the assessment, well, you are going to use cage. If it's positive, you are going to do audit. If it's drug related, you are going to do cage aid. And if it's positive, you're going to dust. So the seabird is like the house, and everything is what you use inside is audit, dust, cage, questionnaire,
Hmm.
in order to push the patient towards the right treatment afterwards. Does it make sense?
Yes, okay. So let me try to explain. Let me see if I understand what you just told me. Except like because I saw some questions whereby I saw three of these, posted to me. So a patient, patient uses alcohol, and like they have these four options. The sleep expert was there, Kate was there, and Dust was there, KHT was there, and kind of got confused. It was one that
Yeah.
I picked expert and I
So
failed it.
um send those questions to me so I can look at it and I kind of be
Okay.
able to evaluate it a little bit more in detail, what is going on.
Okay. So let me see if I understand what he just said. So when a patient comes in and you don't know, like the patient present to you, like someone that deals with drugs and alcohol, you have to use expert. Then in the process of using expert, you use like cage, depending on what the patient tells you. Use cage, that
Right.
cage T, audit C. You cage before
Yes.
audit, right?
Cage before audit, yes.
Cage before audit. Cage. Then that means if the cage is positive, which is like 2 or more,
Exactly.
that means we have to extend it to audit. Audit is the one that is more detailed.
Yes, absolutely right.
Audit,
Yep.
audit. Then that's it pretty much.
Pretty
If it's
much.
alcohol, yeah, if it's alcohol. But if it's after screening for cage and there's substance, that means we have to use cage A, right? Cage A,
8, yes.
cage 8. Then dust, does it mean that dust is more detailed than cage A? Well,
Yes, it does.
okay, okay, dust. Okay.
Yes.
Thank you. Thank you so much for everything. Appreciate it.
No problem. No
All
problem.
right. All right.
All
Bye.
right. Bye.
All right. Thank you.
Uh-huh. Next person is yeah, we got 2 more questions and I have to go, folks. Anna, maybe 3.
Hi, good evening. I have a question in regards
Sure.
to, are the medications will be covered in by classification and then each specific on each classification in the crash course?
No.
No. Is that something that you think will be needed for the boards, or is it enough to go through like each module, each condition and the medication explained within the modules?
Yes. But I also did a document for you under the crash course review.
Yes, I saw that.
Talks all about the medications the way it is more than fine.
Okay. All right. So you don't recommend us taking that psychopharmacology course that you have?
Absolutely not.
Okay.
That
All
is
right.
that is overkill and unproductive. It would not be helpful to you
Okay.
because it's too much. You don't need it.
Sounds good.
Okay.
Thank you so much.
All right. Okay. The next person is
Obianuju.
yes. Please go
Good, e-
ahead.
good evening, Dr.
Good evening.
Lopez. Thank you very much for your
Yeah.
dedication and commitment to us.
Yeah.
We
Of
can
course.
we can't thank you enough. It's just enormous. Thank you.
Yeah. Absolutely. How
Mm.
can I help you?
Yeah, my question is just about something caught my attention about the arrest of a patient. I guess I stepped out when it was mentioned yesterday, so I didn't get that, and I didn't want to miss that because someone mentioned that they saw it in their test today. So I just wanted to have a brief overview of what it
Please,
is about.
can you give me a little bit more details?
Okay, so I wasn't here when it was mentioned, but someone did pass his test today, and he mentioned about a patient that had to be arrested, I think, for their
Oh,
own safety. So, but I didn't know in details what that was about, so I just wanted to
yeah.
clarify that.
I'm not sure exactly